All right, guys. So I'm gonna go try to screen share and go from there. Can you guys see my screen? Yes?
Yes.
Yes.
Okay.
Yes.
All right. Slideshow and play from start. Okay. So I will tell you that I'm not very good at keeping track of the chat as we go through the slides. I am doing this by myself, so please, if anybody has questions or comments, feel free to make this as interactive as you want this to be. No need to be shy. So I'll start off here. I see Oz has joined us. You know, I almost feel like I should put Oz's name on this slide as well. I keep all the names on here. These slides were Rahul's slides. He was the brainchild of this review session. All the sessions were his, and he started handing them off. So I never take his name off because he really created the content. I left Aziz's name on too. He was my partner in crime last year, but I think he is working clinically tonight. So it's just me. But I think Oz also deserves special mention since he always organizes this for the benefit of the residency and honestly for the benefit of all of us, including the attendings who can go and review this content. So we'll go ahead and start. At least I'm going to try to start. Let me see. If it will. There we go.
Thank you, Eddie.
You're welcome. My pleasure. Thanks for joining us, Oz. All right. So we're going to start off with pelvic fractures. Know that they constitute 3% of all fractures with a mortality rate of about 20 or up to 20%. Most occur secondary to motor vehicle accidents. 25% of them are from falls in the elderly. Pubic rami involved in about 70% of all pelvic fractures, with a single pubic ramus fracture being the most common. For example, after a fall onto buttocks. Note that the pelvis supports weight in either the erect or sitting posture, or I guess that would be the upright or sitting posture. Pelvis serves the purpose of protecting the GU and GI systems and the neurovascular plexi. And pelvic fractures are associated with about a 5 to 10% bladder injury as well. Sorry. Let me see how I can scroll through this. I think I just have to click like that. Okay. Pelvic anatomy, 3 main bones. So the sacrum, the 2 innominate bones that are made up of the ilium, the ischium, and the pubis on both sides. There is stability to the pelvis provided by the sacroiliac joints, the as well as the sacrotuberous and sacrospinous ligaments. Most common dislocation site is either the symphysis or at the SI joint. The SI joint, if you can see my cursor, of course, is where the sacrum meets the innominate bones posteriorly. Okay, here's another depiction, kind of a cartoon depiction. Again, here are your SI joints on either side of the sacrum and your pubic symphysis. And note that the pelvis, of course, is a very vascularized structure, or that there's a lot of vascular structures within the pelvis. So some classifications to discuss. The Young classification based on the vector of force, so AP compression, open book fractures, lateral compression, for example, in an MVC, and vertical shear, fall from height. It is in red letters that it is highest mortality. You may see that question on your exam. And here's just a depiction of how the vertical shear occurs. Pretty serious injuries when it occurs. So here's an X-ray depiction of what we're talking about. There's the open book fracture. As you can see, there is separation of the pubic symphysis. What's a little more subtle, but not so much, is that there's also some SI joint involvement, right greater than left, or just maybe on the right here. This shows vertical shear. So here is your shear site, roughly at the SI joint, where the sacrum meets the left innominate bone. As far as treatment, number 1 is hemodynamic stabilization. 50% of pelvic fractures will require transfusion, and of those requiring transfusion, 80% of those will hemorrhage from the pelvic fracture site. 30% of those requiring transfusion will die. So you must differentiate from between pelvic hemorrhage and intra-abdominal hemorrhage. If unstable, this can be done with an XLAP, DPL, or FAST. DPL, for the most part, is falling out of favor. I think I'm a PGY 17 now, and I've only seen one, and it was during my residency up at Columbia, and I haven't seen one since. I think ultrasound has really just supplanted the use of DPL. If you're going to do it, though, the lavage should be supraumbilical to decrease false positive results. CT scan can be considered in stable patients. You don't want to send your unstable patient over to CT where they may hemorrhage to death. So retroperitoneal hemorrhages, venous are the most common, need to be considered if they're not responding to your interventions. Fluid resuscitation, blood replacement, also consider small or medium pelvic arterial bleeding, usually not explored because of angiography and embolization as an option. They're usually not explored surgically. Consider cystography if suspected GU injury. Following hemorrhage, the second major determinant of morbidity and mortality is the presence of other associated injuries like head injuries, neurologic, well, they kind of go hand in hand, GU, abdominal, etc. So the mortality from these high energy pelvic fractures, 42% when hypotension is present at their presentation, 50% with a head injury requiring treatment, 53% if there's a concomitant intra-abdominal injury, greater than 90% if all of the above are present. So what's our first step for unstable pelvic fractures? Pelvic binders. Now, this is a pretty fancy setup they have here. I think we have that at Cornell. Pretty sure Columbia has it as well, but when this is not available, you can make use of a sheet and use a pole or something to make it kind of tourniquet it into place, but you want to bind the pelvis to kind of tamponade the bleeding. We'll move on now to some hip disorders, hip fractures, etc. So the hip anatomy. Note that the hip has a strong fibrous capsule, which is weakest posteriorly with a tenuous vascular supply. So what that means is most of your hip dislocations are going to be seen as posterior dislocations. As far as fractures go, femoral neck and intertrochanteric fractures cause a lot of problems with vascular disruption and the requirement for repair. The incidence of these fractures increases with age, likely due to falls, with a greater incidence in women than men. Morbidity, approximately 30%, mortality, 8 to 10%. You'll see clinically shortened, externally rotated, and abducted lower extremity. So treatment, this is what we do: immobilize, give analgesia, consider surgery as soon as possible. There may be aseptic necrosis if they don't undergo surgery. Truth is, very often the joint's going to be replaced anyway. Consider other associated injuries, especially ipsilateral injuries on the pelvic of the pelvis, other fractures, sciatic nerve involvement, vascular involvement, possible embolism. Note that plain films alone do not rule out a fracture. So if you have someone with a decent story who can't ambulate, can't weight bear, move on to advanced imaging. Here it says CT and MRI. Realistically, we're looking at CT in the emergency department to evaluate for occult fractures missed on X-ray. A cartoon depiction of some different types of fractures. So this is a femoral neck fracture that is going to very likely disrupt the blood supply. This is an intertrochanteric fracture because it spans from the greater trochanter to the lesser trochanter. You should know the nomenclature so that when you call your consultants, you can describe the fracture that you're seeing. So here on X-ray, you can see that there is a femoral neck fracture over here, and here there's a fracture line depicting an intertrochanteric fracture. Some may say that you can't readily see this fracture here, but it is impacted. The big clue here is the disruption of the normal contours of the femoral neck. Hip dislocations, about 10 to 15% of all dislocations, with posterior being by far most common due to the inherent weakness posteriorly of the hip joint. A well-documented neurovascular exam is mandatory. Documentation is important, but make sure you're performing a thorough exam. 10 to 15% of those posterior dislocations will involve the sciatic nerve, Anterior dislocations typically involve a greater mechanism, a greater force mechanism, and may involve the femoral artery, vein, and nerve. 50% of the time there is fracture elsewhere. The treatment is prompt closed reduction under general anesthesia in general. That's what they're saying, general anesthesia, although we do it in the emergency department with procedural sedation. 50% will develop post-traumatic arthritis. What we tend to see is shortened, internally rotated, and adducted, posteriorly adducted, and for posterior dislocations, this is what you'll see, shortened, internally rotated, and adducted. So that's just a depiction of a posterior dislocated prosthetic hip. By and large, when we're seeing dislocations in the emergency department, when we're talking about hips at least, most of them are going to be prosthetic hips. There is some inherent instability with these prostheses. Here, you can appreciate that here's the cup. Can everyone see my cursor? So here's the cup. Here's the ball. This ball belongs inside this cup. Note that the cup has a liner that's not really radiopaque, which is why the cup looks so large relative to the size of the ball. But it fits well because there's a typically polyurethane or other plastic type of liner that occupies some of the space of the cup. So here we can see in photograph form some of the pathology that we're talking about. So what is this here? This is a posterior dislocation. Here we've got a fracture at the hip. Here we've got a rarely seen anterior dislocation. Femoral neck fracture, anterior hip, posterior hip. Now we'll talk a little bit about some pediatric hip disorders. So congenital hip dislocation, most common in firstborn females, less than a year of age. You may note a click on the affected side with the Ortolani maneuver. If you're not familiar with it, please look it up. Septic arthritis of the hip, usually occurring before age 4. You will see patients with toxic appearing patients with fever. They may be irritable. They will be irritable. Limping on the affected side. X-rays may show a fusion and joint space widening, and the type of pathogen seen depends on age in general, with newborns associated with Staph aureus, Group B strep, gram-negative bacilli, infants, H flu, strep, staph, and other children, Staph aureus, strep. Some of this may have changed. Again, this is an old talk, so I can't tell you for sure that none of this has changed, but that was the teaching when I went through. So evaluation, oops, let me see if I can go back there. Yep, x-rays, labs, and admit. Leg calf Perthes disease, typically seen in males 5 to 9 years of age, limping with pain of weeks to months duration, often caused by recurrent episodes of thrombosis and infarction of the femoral head. They will typically be afebrile, not toxic. Again, this is kind of chronic pathology here. They'll note decreased range of motion with abduction, internal rotation. X-rays may show joint space narrowing, and later you'll see increased density, smaller stress fractures, and a pacification of the femoral head. This almost looks similar to like the bony infarcts that we sometimes see with sickle cell disease. Scyphes, or slipped capital femoral epiphysis, in the pre-adolescent or adolescent male, typically obese or sedentary, or tall and thin but in a growth spurt. The history will typically be very trivial trauma, decreased range of motion. It disrupts the capsular blood supply, high incidence of AVN if it's not recognized. A frog leg view may show widening of the epiphyseal plate and capsular swelling. I think I have an x-ray to show you of that. Okay. So here we see just how it slips a bit, where at the growth plate, the head kind of just slides off. Here, an x-ray depiction, you can appreciate that there's a difference here versus the other side. And this is a leg calf Perthes. So you can see a pretty healthy appearing hip joint with the growth plate, and one that's been repeatedly infarcted and is not healthy. So here's a normal pelvis x-ray. Shenton's line. Can anyone tell me what Shenton's line is? No takers? Can everyone see my mouse when I move it? Can you see it?
Yes.
Okay, so this is Shenton's line here. If you look at this, it should be pretty smooth as you trace this track here, right? Same thing on the other side. If you don't see a very smooth transition here, you need to suspect an occult fracture. So we went back a few slides where we had that femoral neck fracture. Let's see if I can, I don't know that I can easily go back to it. You would see that there is a disruption though. So there's Shenton's line there. All right, the Salter-Harris classification for pediatric fractures. I think you guys have seen this a lot. There is a mnemonic. Salter itself is the mnemonic. Is everyone familiar with these fractures? Stop me if you need this in more details, but type 1. So think of it as, if we're going to use Salter as the mnemonic, slipped. Type 2, above. Type 3, lower or below. Type 4, through. And type 5 is kind of like crushed. So I remember it as everything is involved. But anyway, SALTER. Okay. All right, let me shrink this a little bit. So the femur, the longest, strongest bone in the body. Femoral fracture can hide about 1 liter of blood. You need to consider associated ipsilateral or same-sided fractures, dislocations, soft tissue injuries. These fractures are commonly seen in children and adolescents, typically due to trauma. They're going to come in with an obvious deformity and significant pain. Treatment includes hemodynamic stabilization, immobilization, analgesia, looking for neurovascular impairment, and early ortho consult. So very often we'll see these patients, and if EMS has them, they'll put them on a hair traction splint, which is kind of a leg lengthening device, which can serve as a temporizing measure to stabilize. Has everyone seen the hair traction splints? Does everyone know how to use a hair traction splint? That's a good thing to become familiar with in case you need to put one on somebody. All right, here we're going to get a little interactive if we can. So I'll read them if someone can jump in with the answers and we'll go through it. 30-year-old man with an unstable comminuted pelvic fracture, vital signs 90 over palp, heart rate 120, respiratory rate 24. Which of the following is the most immediate appropriate next management step? Angiographic embolization, application of a pelvic binding apparatus, application of an external fixator, skeletal traction, venographic embolization.
2.
Number 2 is correct. That is right. That is your next immediate step. Posterior hip dislocations. Which is the right answer? Are they less common than anterior hip dislocations? Most commonly result in compression of the femoral nerve. More commonly associated with fractures of the femoral head than anterior dislocations. Associated with an inability to see the lesser trochanter on an AP X-ray view. Cause the patient to have an externally rotated abducted and shortened leg. If I had the music to Jeopardy, I would play it.
Externally rotated abducted shortened is the femur fracture, right?
Yeah, so that's not the right answer.
Right, and so I don't think it's 1 or 2.
So you're doing great so far.
So it's 3 or 4. Fractures of the femoral head. I'm not sure about that, but I don't know if it's posterior.
So yep.
It's 3 or 4. Maybe it's 4. I don't know.
It is 4. As you're internally rotated, you're going to hide that lesser trochanter, as you can see here. So here's the lesser trochanter on the left. You don't see it on the right because of the rotation. Never to mention the fact that the ball is clearly out of the socket as well. Which type of pelvic fracture is most often associated with the highest mortality? We mentioned this earlier. AP compression, vertical shear, lateral compression, crush injuries, combination injuries.
Probably vertical shear, right?
That is correct. You're going to do very well on this test.
I don't know about
Which of the
that.
following factors is most likely to disrupt perfusion of the femoral head? Subcapital, intertrochanteric, subtrochanteric, pubic ramus, avulsion of the greater trochanter.
I don't know. I don't know what a subtrochanteric is. Subcapital. I mean, maybe intertrochanteric.
That's a good guess. That was actually my first guess, but it's subcap.
So where is that fracture?
Say again?
Where would that fracture be then? Right below the ball?
Capital, just below the ball. The cap of the ball. So like here, I guess it would be just right here. Think of it as like
the ball is where all the vasculature is, right?
Yeah.
Whatever's closest to the ball.
It traverses across the neck. So you take that cap off, you're going to disrupt that blood flow. All right, 6-year-old boy presents with complaint of worsening atraumatic left knee pain for a week. Parents deny history of fever. Patient is afebrile. Physical exam remarkable for a slightly overweight white boy with a limited range of motion of the left hip secondary to pain. The exam is otherwise negative. Radiographs are ordered. So even if I didn't tell you all those first 4 or 5 sentences, just looking at the x-ray, what has he got?
Looks like maybe 1.
Yeah, I'd say so. Doesn't this look different than this? Yeah. There's been some generation of that. So be familiar with the x-rays because that might be all that they give you. Sometimes what they're giving you in the foil is all fluff. Or in the question, it's all fluff and the x-ray has the answer for you. So be comfortable. I mean, you should read it, but be comfortable also with seeing the x-rays themselves. All right. Which of the following treatments is most appropriate for the following injury? So what do we got here?
This is a dislocation, right?
Yeah, and it's a native dislocation, which is pretty interesting. So what do you do for that? What's our immediate treatment?
I mean, can't we just reduce it in the ED?
Yeah, that's exactly what we should do. Immediate close reduction in the ED. And despite what that earlier slide said about general anesthesia, we can do this under procedural sedation. A little bit of propofol, and that should do it. Some hospitals do not allow ED providers to administer moderate sedation, just so you're aware. But in general, I'd say go for it. All right, knee injuries. Fractures of the knee are uncommon. Knee injuries are highly associated with ligamentous and or meniscal injuries. Mechanisms of injury, severe valgus or varus stress, falls, or bumper fender. That's where you get hit with the bumper of a car. Clinical presentation, pain, swelling, deformity, effusion, instability, crepitus, and hemarthrosis. Neurovascular injury is uncommon but must be excluded. Goal is restoration of the articular surface. So here's just some. Okay.
I think I'm in charge of this right now, by the way. What's going on here?
Sounds good. So this just kind of shows you varus and valgus deformity at the knee joints. All right, let's see if I can try to make some of what's here shrink away so it doesn't block. Okay. Dislocations, true knee dislocations, that is dislocation of the tibia relative to the femur are orthopedic emergencies. 40% of the time there is involvement of the popliteal artery, which must be excluded 100% of the time. Note that when you're talking about dislocations, we're talking about the distal bone relative to the proximal. So we're going to talk about this as an anterior dislocation because the tibia is dislocated anterior relative to the femur. Immediate reduction is key, and you must get early angiography or operative exploration to make sure there is not vascular compromise here. We'll talk a little bit about the Ottawa knee rules. So by the rules, order the x-ray if the patient is more than 55 years old, if there's tenderness at the head of the fibula, isolated patellar tenderness, inability to flex to 90, inability to transfer weight for 4 steps immediately after injury and in the ED, 97% sensitive, 27% specific, so not very specific at all. Off the record, if you're working with me, get the x-ray. I personally don't care about Ottawa rules. I think in this day and age, it is way too easy to get an x-ray in an ED setting to not do it. We'll talk a little bit about patellar fractures here. About 1% of all fractures in all age groups with 2-to-1 male predominance, typically from direct blows. Clinically, they'll present with pain, of swelling, palpable defect, hemarthrosis, and disruption of the extensor mechanism because the patella acts as a fulcrum for the knee. So if the patella is not in place, they lose their extensor mechanism. Differentiate from a bipartite patella, that is a congenitally split patella. Treatment, aspiration of the hemarthrosis, cylinder cast surgery. So this is pretty interesting stuff in that, like, here we have an undisplaced fracture, but that could get displaced. A transverse fracture, lower pole or upper pole, comminuted displaced or undisplaced, vertical, and what does this say here? Osteochondral, so involving the cartilage. The treatment for vertical fractures that do not involve the quad tendon or the patellar tendon very often is non-surgical because there's nothing to pull it apart. But if you have a transverse fracture, the quadriceps muscle works to pull that patella fracture line apart. And thus those are almost always surgical. Patella dislocation, laterally dislocated, is the most common, secondary to a direct blow, or flexion, external rotation, and quad contraction. Clinical presentation, you may see an obvious lateral deformity, and when you reduce it, and they're fairly easy to reduce, they typically will develop swelling and a bloody effusion. Nevertheless, that is the treatment. That is what you want to do. Immediate reduction. So flex at the hip while extending at the knee with gentle medial pressure or medially directed pressure to pop it back into place. And then you may consider aspirating the hemarthrosis and immobilization and full extension with crutches. Here's a depiction of what it looks like. Looks pretty painful, thin guy. This should be easy to pop into place. My clinical experience is that you don't have to flex the hip. You just have to fully extend the knee, and that typically does the trick, and then you pop it back into place. So the reason why it tends to dislocate laterally and not medially is because the ridge on the femur is higher, so it's a steeper slope medially than laterally. That's why it tends to pop out laterally. All right, some other structures that you should be familiar with. So this is where you would see the quad tendon, the patellar tendon, lateral and medial retinaculum. And this just shows where the muscles kind of come into play here. Extensor tendon injuries. So normally the knee extensor tendon does not rupture under stress, but 88% of the time quad ruptures in people over 40, 80% patellar tendon ruptures in people under 40, where the mechanism is sudden violent contraction of the quads against weight with the knee flexed. You may note a palpable soft tissue defect, what we would call bogginess, with loss of extensor function. So they can weight bear, they can stand, but they can't really walk. The static knee stabilizers are intact, but they popped one of their tendons. Knee immobilizer, crutches, and that can be outpatient follow-up. So here's another cartoon depiction of the knee joint. So you can see that there's some stabilizing structures like the lateral medial collateral ligaments, the ACL. What you don't see here is actually you do see a little view of the PCL back there. They cross each other. And then you can see the lateral and medial menisci as well. Note that the knee is the largest synovial joint in the body, surrounded by many stabilizers, both static and dynamic. ACL is the most frequently injured ligament of the knee. Injury to the medial aspect of the knee is more common than lateral. Static stabilizers classified according to location. The mechanism of injury typically involves valgus or varus stress while weight bearing on a fixed foot and flexed knee with some degree of rotation. They may note or feel or hear a pop or a snap followed by pain, rapid swelling, and hemarthrosis. Varus and valgus stress to see if there's any instability. Also do the anterior posterior drawer. I very rarely do the anterior draw. I prefer the Lockman's maneuver, and I'll show you a cartoon depiction of that in a little bit. Here it says to accurately test knee collaterals, flex to 30. So you're kind of disengaging the collaterals, which allows you to really separate out the ACL when you do it as a Lockman's. All right, so here's just a cartoon depiction of an ACL tear and a PCL tear. All right, so for our exam of the knee, this is the Lockman's. So kind of a depiction of how that's done versus the anterior drawer. The anterior drawer is easy to do, but that lateral and medial retinaculum can give you some instability, some false stability that's not really there. And that's why the Lockman is considered superior. Meniscal injuries, often associated with ligamentous injuries. It's difficult to accurately diagnose in the acute injury setting, but there are some maneuvers that we can do. The less mobile medial meniscus is more frequently injured than the lateral. The mechanism is sudden rotation and extreme flexion or extension with crush of the meniscus between condyles. So think of it as fully extended, weight bearing, and turning. Clinical assessment, pain along the joint line, painful external rotation means medial meniscus injury, painful internal means lateral. So the tests that I'm referring to are the Apley's and the McMurray's tests. So here on the left is the Apley compression test, where you kind of like push down as you try to basically sandwich the menisci between the femoral condyles and the tibial plateau. And the McMurray test is somewhat similar in a different position, where you're kind of compressing the lower leg between your hands as you rotate the foot in a medial and lateral rotary arc. Okay. So the significance of acute hemarthrosis within 6 hours of injury in patients less than 45 years old. So that's associated with an ACL tear 80% of the time, meniscus tear 50% of the time. So that's more than 100%. So these two tend to go together. Patellar dislocation 15%, fracture less than 10%, PCL less than 2%. You may need arthroscopy and or MRI to confirm. That's not what we're going to do in the ER though. For us, it's immobilize, crutches, pain meds, and ortho follow-up. Immobilize as in a knee immobilizer. All right, tib-fib fractures. The tibia and the fibula are bound together by the interosseous ligament. At its most distal part, it's called a syndesmosis. More than half of the tibial plateau fractures involve the lateral plateau. Fibular fractures are most common on log bones, tibia most common open fracture. So the purpose of the fibula, by the way, is to really give you an ankle joint. The fibula doesn't serve much other purpose. So like if you did fracture, if you had an isolated mid-shaft fracture of the fibula, it would not be a big deal if the tibia itself were not fractured. Osgood-Schlatters disease is a traumatic tibial apophysitis seen in active adolescent males, so they're still growing, with repetitive injury to the tibial tubercle apophysis leading to avulsion, separation, and they'll note swelling and increased pain with forceful leg extension. This is where the patellar tendon attaches to the tibia, and so that traction can lead to apophysitis. Fibula, as I mentioned earlier, is essential for ankle stability and not much more than that. Fibular fracture, it says non-weight bearing. Honestly, if it doesn't involve the distal third, you probably can weight bear. Fibular shaft fractures are uncommon, although a mechanism where you're struck to the lateral aspect of the lower leg could definitely give you a fibular shaft fracture. Nevertheless, look for associated tibial fractures. Look for peroneal nerve injury with proximal fibular fracture. That will be characterized by a foot drop, or it can be. Direct trauma is a major cause, or torsion, rotation on planted foot is another cause. Clinical presentation, you may see pain, swelling, deformity. Make sure you document the neurovascular exam. The Mason-New fracture, so that's a translation of force fracture. So it's a spiral fracture of the upper third of the fibula associated with a tear of the distal tibiofibular syndesmosis and the interosseous membrane, which is pretty much one and the same. That translation of force can give you an avulsed fracture fragment at the medial aspect of the tibia with a medial malleolar fracture and rupture of the deltoid ligament. And again, it's due to transmission of torque or transmission of force across that membrane. So here we can see the proximal fib fracture. That force travels across this membrane, which is not well depicted on X-ray, and that disrupts here the ankle mortise and takes out the medial malleolus. This is the traction apophysitis that we see, Osgood-Schlatters disease. So there we go. So you can see that looks pretty irritated as the patellar tendon continuously pulls traction on that tubercle. All right, ankle anatomy. A lot of ligaments. The typical ankle inversion injury affects the lateral ligaments, as we can see here. So most commonly, I would say, is the ATFL. At the talofibular portion of the ATFL is the one that I believe is sprained most frequently in ankle inversion injuries. Here are some of the medial ligaments as well. Typical ankle fracture. So this is a distal fibular fracture with disruption of the ankle mortise, and as you can see, involvement of a lot of the supporting ligamentous structures. So there's a high incidence of associated ligamentous damage. Here in the X-ray, you can see that there's a fracture, a spiral appearing fracture of the distal fib with violation of the medial malleolus. So they're going to have trouble with weight bearing, sometimes due to pain, but if it's unstable, that may change how it's managed. So if it's stable, usually no reduction, maybe some immobilization. If it's unstable, you need to get ortho involved. They may need to remedy the situation surgically. So this here would require surgery because this is inherently unstable. It's not going to heal with just a splint and probably wouldn't heal with just a cast. And if you don't get this right, they're going to develop an arthritis within that joint. All right, so ligamentous injury to the ankle. At the time this was written, at least, leading cause of ED visits. 80% due to inversion and rotation, high incidence of complications. Lateral ligaments are most commonly involved, such as the ATFL, the calcaneofibular, posterior talofibular ligaments. Medially, the ligaments are stronger and less likely to be injured than laterally. Medial collateral deltoid, that consists of 4 separate ligaments. Look for the associated Mason-New fracture. That can be as simple as just seeing if they're tender on the proximal fibula. Classification, 1st, 2nd, and 3rd degree. Stress testing with x-rays can be helpful in differentiating between 2nd and 3rd degree. That's usually what ortho does, not us. Treatment, compressive dressing or air cast versus splinting versus surgery, depending on the degree of sprain. Really bad sprains sometimes need to be repaired surgically if the ligament is completely disrupted. Okay, Ottawa ankle rules. Again, good to know for the test. I always just get the x-ray. So if there's tenderness at the posterior tip of the lateral malleolus, I'm sorry, that's bone tenderness at the posterior tip of the lateral malleolus, or the posterior tip of the medial malleolus, or inability to weight bear immediately and in the ED. If they came to the ED, my rule is if they came to the ED for ankle pain, just get the x-ray. But the Ottawa ankle rules were designed to reduce the frequency of x-rays, reduce cost, reduce waiting time. This does not pertain to subacute or chronic injuries. This pertains to acute injuries. So the takeaway is if they have swelling without pain, if they're able to weight bear, no x-rays are needed in general. Achilles tendon ruptures, often seen in the middle-aged athlete, 4 to 5 centimeters above the calcaneus, often confused with a calf muscle tear or strain. The mechanism can be direct trauma to a taut tendon versus forceful dorsiflexion with the ankle relaxed. They'll note agonizing pain preceded by a snap or a pop, weakness with pushing off, and a soft tissue gap. I've seen some of these clinically. It's pretty boggy when it's completely separated, and they'll have a positive Thompson's test. That is, when you squeeze the calf muscle, it cannot fire the tendon, so they don't plantar flex. It won't move, and that's a positive Thompson's test. Treatment, splint versus surgery for that. So that deals with partial versus complete. If it's a complete tear, they're going to need surgery to bring those two ends together. Okay. Here's a depiction of the Thompson's test. I'm sure you're all familiar with it. But when you squeeze, if that Achilles tendon is intact, you should see plantar flexion on the side where that calf muscle is being squeezed. See if that shows the movement. I guess not. All right. Calcaneus fractures. About 60% of all tarsal calcaneal fractures. The rule of tens. 10% bilateral, 10% dorsal lumbar. Compression fractures are involved. 10% tibial plateau fractures. Bowler's angle is normally 20 to 40 degrees. Suspect a fracture on a occult fracture of the calcaneus if less than 20. And this is Bowler's angle here. So that should be no less than 20 degrees. If it is less than 20 degrees and you think there's no reason to suspect that there's an occult fracture, you can compare it to the other side. So here we're looking at a measurement of Bowler's angle. I can, just eyeballing this, I can tell you that that's more than 20 degrees. So I know that they don't have an abnormal Bowler's angle on this X-ray. Some more foot anatomy. So these are just some of the bones that we're all familiar with. Okay. So we'll talk a bit about Jones fractures and pseudo-Jones fractures. So it's a fifth metatarsal fracture with a high incidence of non-union or delayed union for true Jones fractures. They need to be non-weight bearing and orthoconsal because these often need to be pinned. So it can be tough to tell what's a Jones and what's a pseudo-Jones because they're similar, or at least they involve the same metatarsal. A pseudo-Jones fracture occurs due to an avulsion at the insertion of the peroneus brevis tendon. It's also known as a dancer's fracture. Not really. The dancer's fracture is really typically a spiral fracture due to some of the maneuvers dancers do, like pirouetting. On X-ray, it can look very similar, though. Here you're seeing a pseudo-Jones, a very straight-looking fracture. If it were more spiral, then I would call it a dancer's fracture. Treatment for this is weight bearing is tolerated, hard-soled shoe. They can go home. They don't need surgery in general. So what's the easiest way to tell the difference? For me, it's a pseudo-Jones if it does not point to the articulation between the fourth and fifth metatarsal. So this is a Jones, right? If I follow that fracture line, I'm at the articulation where the fourth and the fifth metatarsal really overlap. Here, I'm not. Here, I completely miss the fourth metatarsal if I follow the fracture line. So pseudo-Jones on the left, Jones on the right. I hope you guys are still awake. I haven't heard a peep in a while. All right, Lisfranc fractures. They can be subtle. Very often, you're looking at a disruption of the complex with some separation between the first and second metatarsal, or you may be also dealing with a dislocation dorsally of the second metatarsal. So let's take a look at some X-rays here. There's a separation that does not belong. So that's a disrupted tarsal metatarsal joint between the first and second metatarsal.
Hey, Dr. Amores, going back to the Jones fracture, we need to, if a person comes in with a Jones fracture, can they go home and see ortho the next day, or do they need to see someone now?
So I think they can go home, but I would have the conversation with ortho. I would not want to risk the loss of follow-up because of the non-union risk. So if you spoke to ortho and you can document that you spoke to them and they say, yeah, they're going to tell you what you already know. Non-weight bearing crutches, we'll see them in the office tomorrow or the next day. I would be okay with that. But I wouldn't just send these people out to fend for themselves because if it's not on anyone's radar and it takes too long, then there's some incidents of non-union even if it's treated correctly. So if there's a delay in getting definitive care, that's going to bounce back to you, and they're going to ortho's defense in that case.
So what if it's a construction worker at 3 a.m. in a freestanding ED and he comes in with this? You're going to keep him to the morning until you can get in touch with ortho? You're going to transfer him to the main ED? I mean, is this something where you have to figure out if the person is medically literate and has good follow-up and all this kind of stuff, and how confident you are?
I've never worked in a freestanding ER, so I don't know what all the resources are. But intuitively, I would say, yeah, I would have them hang out until I can call ortho fairly early and say, hey, is this someone that can be seen in your office today or tomorrow? You need to concern, this is a little harsh, but you need to concern yourself more with the well-being of the patient than the convenience of the consultant. Because if you don't, you're going to pay a high price. That being said, do you need to wake up ortho at 2 in the morning for this? You
Right.
probably don't. But you need to ensure that there's an appropriate mechanism for follow-up. So if I had a reliable patient, I might say, hey, it's 2 a.m. Why don't you go home with these crutches? Don't put any weight on it. I'm going to call the orthopedist in the morning, and then I'm going to call you. And I'm going to let you know what the orthopedist said. And I think that would be acceptable. So if my shift ends at 7 a.m. and I call ortho, even if I'm talking to them at 7:15, say, hey, I saw this guy in the middle of the night. I sent him home, but I told him he needs to see you. And I told him I would call him back to let him know when he's going to see you. And they might say, hey, tell him to call my office. Tell them that I said I need to see him this week. Good enough. You've closed the loop. I would close that loop somehow, and I would make reasonable accommodations to not wake my ortho unnecessarily. So I don't think it's unreasonable to send someone home as long as you know you can reach them later. I would just call them later. That's what I would do.
Okay, makes sense. Thanks.
Yeah, sure. All right. So, and thanks for asking, because I want this to be interactive. All right. So a few more questions here. We can try to breeze through these. You know, these questions, they feel painful a little bit to go through, but these are the questions that you might see. Oh, I already gave the answer on this one. You might see some of these on your exam. So anyway, 20-year-old woman, sprained ankle while running, able to walk for a short distance. Then and now 4 steps in the ED. Radiographs are not indicated unless exam also reveals absence. I'm sorry, not indicated if the exam also reveals absence of bony tenderness where. So there's 2 spots. Remember, we talked about the posterior edge of both the medial and lateral malleoli. So it's got to be on both sides. Let's see here. All right, 42-year-old male presents with foot pain after jumping from a ledge, reporting difficulty ambulating in the ED, and an X-ray is obtained. Which of the following is true? The fracture fragment indicates that the ligaments are intact. This is a stable injury. Degenerative arthritis is the most common complication. Subtle plantar displacement is sometimes the only sign of this injury. Posterior tubular artery may be damaged during this injury.
So this is a Liz Frank, right?
Yeah. So that takes out number 5 right there, right?
Yeah, and it's definitely not stable. A fracture fragment indicates the ligaments are intact. I don't know about that. Maybe that
would be an avulsion fracture, not a Liz Frank fracture. Yep.
So 3 and 4, what are the answers now? I'm leaning more towards 4. I don't remember. I think you said something about arthritis, but I don't know if it was for this one.
Yeah, I would go with 4 on this one. Remember, I said with Liz Frank, you can see the separation or a little bit of subtle displacement. And I believe it's 4. Let's see. I actually have to go to the next slide to check myself, but I believe it's 4 also. Let's see here. Nope, 3. All right. You know why? It's not plantar displacement. It's dorsal displacement. That's why that's wrong. Yeah. All right. So it tricked us both. Maybe Paula too. She didn't vote though. Let's see here. Paula, you can vote if you want. Let's see here. 35-year-old male presents after significant hyperextension injury to the right knee while playing soccer. On exam, the knee is severely unstable in both AP and lateral direction. Palpable hematoma is present in the popliteal fossa. Plain film show no bony abnormality. Which of the following tests must be performed next?
It sounds like he might have dislocated.
What are the key words here? Significant.
Yeah, it sounds like he might have dislocated. I would say
his knee. That's what it sounds like to me, right?
Yeah, so
he may have dislocated his knee and may have reduced himself, right? It mentions a significant hyperextension injury. You're not supposed to hyperextend past 180. So a significant hyperextension injury, severely unstable. So if you read this, they're telling you the answer. It's unstable in pretty much every direction, right? AP and lateral. There's a palpable hematoma in the popliteal fossa. How did that get there? Plain films show no bony abnormality. Why? Because this isn't a bony problem. This is a ligamental problem. This is a vascular problem. So which one are you going to do?
Maybe 2.
Yep. Arteriography. All right. Finally, we're off the lower extremities. So last year, Aziz did all the lower extremity, and I did the upper. I don't know why. I kind of like the upper better, but Here we go. Shoulder anatomy. Shoulder is a impressive, unstable joint, as I'm sure you're aware. All right, let's see here. So this is a normal X-ray. As you can see how the different bones come together. Shoulder girdle is made up of 3 joints and 1 articulation. The SC joint, the AC joint, glenohumeral, and scapulothoracic articulation. Neuroexam should include assessment of the axillary nerve, tested with shoulder abduction and lateral arm sensation, like over the deltoid. X-rays, AP lateral, scapular Y, and axillary view. That may be overkill. I don't think you need all 4, but you need AP lateral and one of these 2 to really assess your dislocations. SC joint dislocations can vary from minor sprains to complete dislocation. Anterior are more common, and that's a good thing because posterior can be pretty ominous. Associated with vascular or pulmonary compromise, prompt reduction is required. How do you promptly reduce these? Very, very carefully. I haven't seen it myself. I've heard of stringing wire, like the sternal suture wire that they do open heart surgery with. Wrap that around. So you got to puncture the skin, wrap it around, and then pull it forward to reduce. Pretty impressive stuff, but I haven't seen it firsthand. Clavicle fractures, most commonly fractured bone in children. You must include a careful neurovascular exam to rule out brachial plexus or vascular injury. Most commonly, you're going to see fracture of the middle third of the bone. Medial clavicle fractures may have associated thoracic injury, very similarly to the SC joint posterior dislocations. AC joint sprains and dislocations. So you may see AC joint separation after a fall into the shoulder with an adducted arm or on an outstretched arm. Violation of the AC or CC ligaments. If the clavicle is displaced upward more than 50%, this suggests complete dislocation grade 3 and likely needs surgery. I think that's actually inaccurate. The way I learned it in sports medicine is 4, 5, and 6 typically need surgery. 1, 2, and 3 can typically be treated with a sling. What you're looking for is to make sure that the AC joint has some overlap. If there's no overlap at all, you've got at least a grade 4, and that's going to require surgery. All right, so grade 1 is just a sprain without a tear. Grade 2 is a tear without real movement. Grade 3 is a tear involving the AC ligament, the CC ligaments with some separation. But that may still be okay with a sling. Now this, I would say, is at least a 4. So that's complete separation. So what you're not seeing on this X-ray is that you've bagged the AC ligament as well as the CC, the coracoclavicular ligaments as well. All right. Glenohumeral joint. So dislocations. Anterior is 98% of the time more common. So the opposite of the hip, anterior here is much more common. You may see the arm in abduction with slight external rotation on anterior dislocations, which again are less common, or an adduction with internal rotation and posterior dislocation, much more common. Reducing the ED, sling immobilization for 4 to 6 weeks, that sounds like a lot to me. 4 to 6 weeks sounds like a lot. I'd want them out of a sling within I'd say 7 to 10 days at most. But for testing purposes, it may be 4 to 6 weeks. Why do I want them out of the sling? Because they're going to get an adhesive capsulitis. They're going to be in the sling that long, the shoulder is going to start to stiffen. Look for associated fractures of the humeral head, as in the Hill-Sachs deformity, or the anterior glenoid rim, which is the Bankart lesion, and for greater tuberosity avulsions. You may note complications such as axillary nerve injury and recurrent dislocations. Posterior dislocations are often missed in up to 50% of cases. You may see that in seizures, electrical injuries, direct anterior blows to the shoulder. Luxatio erecta, I've only seen it once. It's pretty impressive. Shoulder is fully abducted, elbow flexed, and behind the head. They look like they're raising their hand in a classroom.
I saw this the other day. And the ortho came down and moved it from an inferior dislocation to a posterior dislocation. That was their first step. And then from that, they then did the relocation.
Wow, that's pretty cool stuff. I can't tell you I saw it once, and I can't tell you that I remember how it was reduced. I wasn't the one that reduced it, but it was definitely an impressive dislocation in that they could not move their arm. Anyway, mechanism of injury, severe hyperabduction of the arm, resulting in impingement of the humeral head against the acromion. So the humeral articular surface faces inferiorly. Pretty impressive stuff. Let's see here. Okay. So this is a typical anterior shoulder dislocation. One thing that I'll point out is that you'll have a very notable, palpable void under the acromion, and that's my target for injecting lidocaine sterilely for my attempted reduction. I, for the most part, do not procedurally sedate to reduce dislocated shoulders. I think it's much easier to do with intra-articular injection of lidocaine. I don't need any post-procedural monitoring. For most patients, it works well and gets them squared away pretty quick. All right, let's see here. So this just shows some more depictions of normal articulation, anterior and posterior dislocation as well. And as a reference, here's a view of the x-ray. Sorry about that. Some techniques for reducing the shoulder. So this is traction counter traction. This is, I think maybe it's called the MILT. It's an external rotation technique, scapular manipulation, and the Hippocratic method, which is frowned upon. In general, we don't do this because at least theoretically you can cause some axillary nerve damage. Have you ever seen anyone do this?
No, they look like they're doing karate.
Yeah, but anyway, I guess that's their best depiction of how to reduce using the Hippocratic method. I have actually seen an orthopedist do that once, though. It's pretty weird.
I think actually once at Colombia. I think they tried everything else before and had to try.
And so they went to that?
Yeah.
I mean, listen,
someone was doing counter traction and then he was pushing like.
Did it work?
It did work.
I'll tell you, if we were out in the wilderness, I might try this if I had no other choice. But at least so it's not, the problem is it's not standard of care. So if there's a nerve injury, it's going to be hard to prove whether it was caused by the dislocation or caused by your reduction technique. So in general, you need to avoid it. So say no to karate, I guess. All right, what's on the next side? Hill-Sachs lesion. So I think about this as being caused, so when you dislocate the shoulder, the muscles, the supporting structures of the capsule want to pull that ball back into the socket. It misses, so as it pulls the humeral head back towards the glenoid rim, you can dent the humeral head, and there's your Hill-Sachs deformity. So that's how I think of it, as miss on the return as it gets pulled back towards the joint. Whereas a Bankart lesion typically is an avulsion lesion as the humeral head is on its way out, not when it's on its way back in. All right, let's see here. I'm not sure what this is supposed to be showing. It looks like a reduction technique, or perhaps how the Bankart lesion happens. So very often I get x-rays pre and post reduction. That way I have proof of what was there before I started and when I finished. So I think that's good practice. So scapular fractures. If you have a fracture of the scapula, it's typically associated with a high velocity impact. Fractures of the body of the scapula or the glenoid are the most common. There's often other associated injuries. Once other injuries are excluded, you can treat with sling immobilization. Proximal humerus fractures, classified according to the amount of angulation and displacement. You see these typically in elderly women and in a fall from outstretched hand or from a direct blow. 80% of the time, it's a one-part fracture that can be managed with sling and early mobilization. Surgical neck fractures, which present an abduction, should be splinted in that position to avoid neurovascular damage. Shaft fractures should be splinted in sugar tongue with ortho follow-up, or in a coaptation splint. Some of you may have seen the coaptation splint. It's a splint that kind of gets tucked under the armpit, wrapped under and back over the upper arm onto the top of the shoulder. Proximal humerus fractures, the most common associated injury is radial nerve palsy. Have you guys seen coaptation splints? You know what I'm talking about?
No.
When you get a chance, look it up. It's not in this lecture. Again, this is a lecture that's been adopted and adapted from Rahul's days of teaching. But a coaptation splint, you should be familiar with it because sometimes we'll put them on in the ER. All right, so on to elbow injuries. The elbow is a complex joint involving the distal humerus, the radius, and the ulna, allowing for flexion and extension, as well as pronation and supination. With elbow and extension, these structures should be in a straight line. So the structures they're showing here is like the intersection of the radius with the capitellum on the lateral condyle. So for X-ray findings, displacement of the anterior fat pad or the presence of a posterior fat pad suggests a possible occult fracture or dislocation. The anterior humeral line usually transects the capitellum in its middle third. So if you don't see that, you may be dealing with a distal humeral fracture. A line drawn through the shaft of the radius will bisect the capitellum, so that's the radiocapitellar line. Failure indicates radiocapitellar dislocation. I may or may not have a depiction of that. I do. Just shows you what to look for. Okay.
Are you the only one doing this lecture, or is Aziz coming?
Aziz is working clinically, so it's just me. You guys are stuck with me. So we're on a marathon session, more than halfway through though. So that's good. All right, so it looks like this is just showing you some of the nerves and vascular structures involved. So here's our radial nerve, median nerve, ulnar nerve. Radial head fractures commonly involve the articular surface. Capitellum fractures and medial collateral ligament injury are commonly associated. However, many of these fractures are occult and not seen initially on X-ray, can be treated in sling or long posterior splint. Olecranon fractures, typically a direct blow to the olecranon. Think fall on a flexed elbow. Examination of the ulnar nerve is the key here. Elbow dislocations, posterior, most common. Remember I had said it's always about the distal bone relative to the proximal bone. So when we say posterior most common, we're saying that it's the ulna that's dislocated posterior relative to the humerus. You may see marked swelling with the joint at 45 degrees of flexion, reduce with posterior stabilization of the distal humerus and steady traction at the wrist and elbow moved into flexion. Common complications include ulnar nerve and brachial artery injury. Olecranon bursitis, it's a most common site of bursitis. Treatment includes aspiration of the bursa, NSAIDs, possibly steroids. Beware for bursitis due to infection. Wrist injuries. So palpation of the anatomical snuff box just distal to the radial styloid should be performed to detect scaphoid fractures. You can also axially load the thumb. You're either pressing in the snuff box or axially loading the thumb. People can have occult fractures, and missed fractures can lead to a lot of morbidity. So if you consider the possibility of an occult scaphoid fracture, you should just put them in a thumb spica. Colles fracture, fall from an outstretched hand. Dorsal angulation of the distal fracture fragment. You can see median nerve injury 60% of the time. With ulnar, you'll see it with ulnar styloid fractures. Anecdotally, 100% of the time. I always see these Colles fractures take out the ulnar styloid as well. But any profound angulation, interarticular involvement should be referred to ortho. We do reduce these, or at least I do, and you can do them when you're with me. It's good to know and get comfortable with reducing Colles fractures. We can always call ortho after the fact to arrange follow-up. Think of the Smith's fracture as a reverse Colles. That's when someone falls with their wrist flexed, much less common, and you'll see volar angulation of the distal fracture fragment. So you can kind of see the uncommon Smith's fracture, and at the bottom, the much more common Colles fracture. Here we're seeing, again, a Colles fracture where the fracture fragment is basically completely separated from the distal radius. This one here looks to be, this one looking a little backward. I think this is a Smith's. Okay. Yep. So there's your distal fragment, as you can see. All right, scaphoid fractures. So this is what's called the waist of the scaphoid, and you can hide a fracture there pretty good. This one is not really displaced, so you may just have tenderness. Here it's visible on the x-ray, it's not always visible. It's the most common fractured carpal bone, typically occurring as a result of forced hyperextension of the wrist. 15% of the time it's not seen on the initial x-ray, and AVN is the common complication if missed. So always splint, as I mentioned, put them in a thumb spike. No one will fault you for splinting them, even if they turn out not to have a fracture, but you will be faulted for not splinting them. There's your anatomical snuff box. All right, Monteja fractures, Galeazzi fractures. This will very likely be on your exam. The Monteja fracture is a displaced proximal ulnar fracture with radial head dislocation, with commonly radial nerve injuries. Galeazzi fractures are a radius fracture with radial ulnar separation, requiring emergent operative repair. Approximately 1 year ago, my brother fell and developed an open Galeazzi fracture, just from fall from standing height. He fell back, he tripped over something in his garage and fell backwards. So if you want to see an x-ray, a really good x-ray of Galeazzi fractures, I'll show it to you whenever I see you, as I've seen one up close and personal. Radial head subluxation, this is a pediatric issue. It's also known as nursemaid's elbow, where the annular ligament is pulled from the radial head due to distraction and force. Treatment is fairly simple for that. A little bit of pressure, flex the elbow, and supinate the forearm. I actually go in a slightly different sequence. Put pressure, supinate, and then flex. And this is the mechanism. It's traction on the arm, and that radial head kind of just pops out of the annular ligament. So again, a little bit of pressure, pushing that radial head back where it belongs, supinate, and then flex. And here it looks like the sequence is correct. We're going to supinate, and then we're going to flex. Here's a picture of the Monteja fracture, distal ulnar fracture, radial head dislocation, Galeazzi, mid-shaft, or not necessarily mid-shaft, but a radial fracture with ulnar dislocation separation. That's one of the mnemonics, so helps you remember that the Galeazzi, the radius is fracture, with the Monteja, the ulnar is the one that's fractured. It's kind of easy to confuse those two. All right, 35-year-old guy, seizure disorder, left shoulder pain 4 hours after having a grand mal seizure. Physical exam is remarkable for the left shoulder held in adduction and internal rotation, with limited abduction and external rotation. Radiograph is obtained, which of the following describes appropriate management. So what is this? It's an anterior dislocation. So what do you want to do? Conscious sedation for closed reduction, ortho referral. Yeah, that, all right. We don't even need to go through the rest, right? That's the answer. Physical therapy, sling and swath with MRI within 72 hours. That sounds like a bad idea. Sling and swath with PCP follow-up in a week. What is the PCP going to do other than send them back to us and tell us to do this right? Which of the following techniques is not recommended for reducing an anterior shoulder dislocation?
I don't know what leverage is, but maybe forward elevation. I'm not sure.
So I think leverage is the answer. I think leverage is referring to that Hippocratic method where you're using your foot to gain leverage.
Yeah.
So you're providing your own traction. Let's see what it says. I believe it's the leverage. Yeah, leverage. So that, basically, I should modify this and maybe put in the Hippocratic method, but that is what they're talking about there. All right, after flexing the shoulder and applying traction to the arm, which of the following techniques should be used to perform scapular rotation? So when they say flexing, they're talking about forward flexion. So the arm is brought forward of the body at about 90 degrees, and they're applying some traction to the arm. So what do we do here? A, push towards B, disengaging the dislocated humerus. C towards B, C rotated towards D, humeral traction moves D, pressure on E and A.
I think it's either 2 or 3, and I think it's 2. Yeah.
So wear gloves if you're going to be handling strangers and touching their armpits and arms, etc. But you know. All right. Pediatrics. 9-year-old boy fell off the monkey bars into his hand, falling. It sounds like, I guess, fall into outstretched hands. Presents with the following injury. What's the most appropriate treatment? So what is this? Here's the fracture, right? Here's the disruption here. And we know that because if we try transecting the lines, I think the anterior line is going to be off here. But I also believe I see a fracture line here. So how would you treat this? Closed reduction and hospitalization for a day. Hemarthrosis aspiration followed by sugar tongue splint. Long arm cast for 6 weeks. Posterior splint for 2 weeks and then progressive mobilization. Sling and swap with early mobilization.
Is it 3?
I would vote for 4. I think we use posterior splints a lot in kids. And this is probably a supracondylar fracture. So I'm going to go with posterior splint. Although you may be right, Paula, maybe Ortho is going to put them in a cast for 6 weeks. We don't cast them. Oh, look at that. Closed reduction and hospitalization for a day. Wow. Shows you what kind of a pediatrician I am. Okay, so closed reduction. That's interesting. Okay. I'm not even sure I would pass this exam I'm supposed to be preparing you for. Which of the following mechanism is most likely to result in an anterior glenohumeral dislocation? All right, so anterior shoulder dislocation. We know posterior is the most common. So this is the uncommon one. What's the mechanism? Abduction, extension.
This is shock.
External rotation, forceful, maybe. Electric shock, seizure, direct force. I'm not sure. Let's see here. Forceful internal rotation and adduction. I think that's going to pop you out posteriorly. I'm going to vote for 1. You're going to vote for 3. Let's see what we get.
1.
Okay. All right. Hand anatomy. Fun stuff. So there's your distribution of the nerves. Right. Normal hand position of function. Right. That lets you hold the beer can in normal position. All right. Hand alignment. All fingers should point, or at least the 4 non-thumb fingers should point towards the scaphoid. If they're rotated, here's your rotational deformity, right? So there's a problem here, as we can see. Actually, it looks like 4th and 5th are problematic, but definitely 4 is not pointing towards the scaphoid. Some common hand injuries. These will be on the test, I believe. Carpal dislocation, scapholunate, the lunate and the perilunate. So scapholunate, people also call that the Terry Thompson sign. There's some other names, but there's separation between the scaphoid and the lunate. So there's widening there on the x-ray. This is your lunate dislocation with the spilled teacup, and then the perilunate where the capitate is off the normally located lunate. Median nerve compression is a common complication as the dislocated lunate enters the carpal tunnel. All right, so which one is this? Lunate, perilunate?
Are you asking what? Okay, never mind.
No, I was asking, but anyway, perilunate, right? So this is perilunate. This is the actual lunate over here. This is the spilled teacup. So this is the capitate is off the normally located lunate. Here, the lunate itself looks like it's been toppled over, i.e. the spilled teacup. Name this fracture. How about find this fracture? Where? I think there's. This is supposed to be it. That looks pretty well corticated, though. Now I know what they're pointing to. All right. So what's the name of that fracture? So it's the triquetral. And what happened? Let's see here. So The triquetral fracture, I remember it as a triangle-shaped fracture sitting dorsally. That's how I remember it. And because it's triangular shaped, at least on x-ray, that prompts me to remember the triquetral fracture occurring from forced hyperflexion at the wrist. It's the second most common carpal bone fracture after the scaphoid fracture. Best seen only on the lateral x-ray of the wrist, i.e. in this view. Splint and ortho follow-up. All right, some finger injuries. Here's our boutonniere deformity due to a central slip disruption. See if this shows just normal anatomy here. I think so. Okay, mallet finger. It's a flexion, forced flexion at the DIP joint that ruptures the tendon. So the extensor tendon is actually avulsed off the distal phalanx.
Wasn't the boutonniere, wasn't that like a leg injury, the boutonniere? What was that?
Boutonniere is a finger injury. Are you thinking of the Maisonneuve?
Maisonneuve, that's what it is.
Yeah. So we have in the arm, the Galeazzi and the Montesia, in the leg, Maisonneuve. Boutonniere is a finger injury. And since we're on it, it's flexion at the PIP with hyperextension of the DIP caused by a rupture of the central slip. You may see it delayed after a blunt trauma. Treat by splinting and full extension. By the way, the mallet finger needs to be splinted in full extension and left alone for 6 weeks. Because if it separates again, you start all over. The swan neck deformity is the opposite of the boutonniere. So here we have hyperextension of the PIP with flexion of the DIP. So this is the mallet finger up top, right? This is the boutonniere, right? Mallet and boutonniere shows you how it happens, right? So the extensor tendon across the PIP joint gives you the mallet finger. It needs to be splinted in full extension. Boutonniere, disruption of the central slip. So you have flexion at the PIP, extension at the DIP, whereas this is the swan neck deformity, which is kind of like the opposite of the boutonniere, where here we are flexed at the DIP and extended at the PIP. If I can go backwards again, right? It's opposite of the boutonniere is the swan neck. Claw hand, hyperextension of the MCP with flexion of the PIP from a nerve injury. Dupuytren's contracture is shortening of the longitudinal bands of the palmar aponeurosis that starts as a nodule. Trigger fingers seen with inflamed MCP pulleys with swelling of the flexor tendon, so it's on the palmar side. And gamekeeper's thumb, injury to the ulnar collateral ligament, frequently seen in skiers. Treat that with thumb spicosplint and follow up with hand surgery. Felon, deep infection of the pulp space, usually caused by Staph aureus. Paronychia is an infection of the soft tissue around the fingernail, so think about like a cuticle infection. Treat with soaks and antibiotics, consider IND. Eponychia is a paronychia with spread to the proximal nail edge. Need minor IND with whip placement. Herpetic Whitlow, vesicular bullous viral infection. Do not IND these because you'll just spread virus if you do. And purulent tenosynovitis, or infected tendon sheath. Look for the 4 canable signs. Fingers held in flexion, tenderness to percussion over the tendon, pain with passive extension of the flexor tendons, symmetrical swelling of the involved digit, what they call the sausage digit. All right, so what's this up here? This looks like herpetic Whitlow to me. This looks like a paronychia that's becoming an eponychia. This is a flexor tenosynovitis. You can have all the canable signs with that. And this is likely a felon with infection of the pulp space.
So eponychia versus paronychia?
It's on a continuum, right? So here, the paronychia is the lateral or medial nail fold, but if it extends to the proximal nail fold, then it's an eponychia. But to me, it's on a continuum. So here I have a paronychia that's kind of becoming also an eponychia. Do you see that?
Yeah, that's good.
Yep, those are easy. Okay, patient presents with a deep laceration involving the volar wrist. Wound exploration reveals a lacerated flexor tendon sheath, although the tendon appears intact. What is the next management step? Close the skin without repairing the tendon sheath. Close the tendon sheath with absorbable sutures. Close the tendon sheath with nylon sutures. Consult the hand surgeon immediately. Examine the wrist through its full range of motion. Paula, what would you do?
I would examine the wrist through its full range of motion.
Yes, you would, because you're a good doctor. You want to see if there's an injury, a partial injury that is sliding out of your view. So yes, exactly. You need to examine it through its full range of motion.
But if you're on your own, this needs to go to the main ED, right, for orthopedics to look?
I mean, you can look at it yourself and document it yourself, but if you think there's violation of the tendon, I'd have a low threshold for getting ortho hand involved. But you can do your exam before consulting ortho. In fact, I would recommend that. I don't know
if you don't have ortho consult, right? We're kind of spoiled in our environments, but
true.
The neuro exam is okay. Sensory, range of motion, and strength.
Yeah.
Depending on the size of the thing, because people cut themselves a lot. So if
Sure.
I mean, obviously, if they're cutting themselves and they come to a ED on their own, I think that you cannot send them home. They need psych overwatch, obviously. But before you close it,
yeah,
my issue would be, what do you think you should just close it or keep it open with a wet dressing?
Well,
after you image it, obviously.
if I were satisfied that this was not a self-injurious attempt, it was truly an accident. So you have an engineer or something was working on an engine, got his hand caught, the flywheel made contact and cut him, and it's believable, then I wouldn't put them on a psych watch. So would I close them? So I would I would ask for permission, this is what I would do. Take pictures of everything I see, irrigate it very, very thoroughly, and then in consultation with a hand surgeon, I would close it so that I can splint it appropriately to send it for prompt follow-up. What's prompt? Next day. Same day or next day. So if I'm seeing this at 3 in the morning, by the time I'm done with the x-ray, the irrigation, the pictures, I'm probably talking to ortho at 6 a.m. Ortho hand or plastics hand, as the case may be, and say, hey, I'm comfortable closing this and splinting this and sending this your way. When can you see them? And they say, hey, I can't see them today. Say, you know what, I'll hold them here and have the on-call person come on in. You may have to transfer. This is high-risk stuff. Taking care of hand lacerations, wrist lacerations is very high risk. You want to make sure you get it right. If you're not sure, then you definitely involve a specialist. I would involve a specialist in some way, shape, or form, but I would be comfortable irrigating, closing, and splinting.
Okay, cool. Thank you.
Sure. All right, so she got that right. All right, 22-year-old man has ring finger pain, injured the finger while attempting to tackle someone during a game of football. Physical exam remarkable for swelling and tenderness over the volar aspect of the ring finger from the PIP joint distally to the tip of the finger. He's unable to actively flex the DIP, although he has strong flexion of the PIP and full extension of both the DIP and PIP joints. Radiographic exam is normal, of course. So what's appropriate management? Buddy taping the finger, extension splinting, hyperextension splinting, referral to hand surgeon for early surgical repair, standard flexion and mobilization of the finger with routine ortho follow-up.
So if you cannot flex the DIP, is this a mallet finger? The problem is it's super
No, a mallet finger would be flexed and unable to extend.
Right, you can extend, right?
Right, so I think this is what they would call a jersey finger, no? Let's take a look. Answer 4, referral to hand surgeon for early repair. Oh, it doesn't explain what it is. So I think that's a jersey finger with a forced extension of the flexed DIP. But we can look that up at the end. I think that's what that is. It's not a mallet finger, though. All right, 25-year-old mechanic sustains injury to his middle finger at the tip from a high-pressure spray painter. He complains of moderate pain.
Hand surgeon. This is always hand surgeon, right?
Sure. Yeah, what has he got going on?
Injection injury, high-pressure injection injury.
Yeah, into the tendon sheath with paint. That sounds really, really bad. So yeah, hand surgeon. I think that's gonna be a washout in the OR. Which of the following is contraindicated? The question. Well, that was the question. What's contraindicated? Not what's your next step. So I think you are correct if the question is what's the next step. But what's contraindicated? You're not going to block this guy. You're not going to add volume to that tendon sheath that's already swollen with pain. So I'm going to go with you and go with urgent or even emergent referral to a hand surgeon. Which of the following complications is most likely associated with the following injury? So what is the injury?
It's not perilunate, it's lunate, right?
Yeah, you can see it here, spilled teacup, right? So now that you know what it is, right, this is like a two-step question. You got to figure out what it is. You got that right. What does it cause? Which of the following is most likely associated with this injury? Avascular necrosis? Maybe. Ganglion cyst? Maybe. Median nerve compression?
Is it that one?
I believe so. I would say definitely. Radial artery compression, maybe. Radial nerve compression. So I'm going to go with 3. I'm with you, Paula. Yep, number 3. A 4-year-old girl amputates the tip of her dominant hand, index finger. The area of missing tissue is 3/4 of a centimeter. The nail bed is intact. The phalanx is not exposed, and radiographs show no evidence of fracture. Which of the following describes the most appropriate treatment? Sounds like she just avulsed some skin. Petroleum jelly gauze, consultation with plastic surgery for a skin graft, undermining the wound edges and primary closure with suture, use of a ronger on the distal phalanx to heal by secondary intention, use of a ronger loosely approximating the wound edges. Do you understand what all these choices are, like what this actually means? Do you know what undermining is? Undermining is when you kind of dissect to loosen up the tissue enough so you can get it to close. And that's something you would do if you had exposed bone, right? You can't leave bone exposed. So if you have a small area, you can do a little undermining to basically loosen up the tissue to bring it together. A ronger is a bone snipper. So using a ronger is to say, snip some bone on the distal phalanx to heal by secondary intention. That makes absolutely no sense. Use of a ronger and loosely approximate the wound edges. But this already tells you that there's no phalanx exposure.
So it's
that takes out 4 and 5. Say again?
So it's 1?
I believe so. You have a little bit of avulsed skin. So I'm with you on 1. I didn't pre-read this, so I can't. I'm with you also taking my educated guesses.
The real question is how much exposed skin does it take for you to say this is not going to heal itself with wet dressing? And how deep? Maybe the question is how much and how deep.
Well, if it's partial thickness, I think it's going to heal no matter what.
Right.
By secondary intention, I think the take-home point is that you cannot have exposed bone. You can never have exposed bone. You've got to be able to close tissue over the bone. And so sometimes when you see people like have a finger amputation, they've lost part of their finger, but there's still tissue all the way. They'll snip down that bone enough to be able to close the skin around it, almost like closing a bag with a twist tie. But there can never be exposed bone. So how much? I guess that's a subjective call. I think any amount of its partial thickness can possibly be allowed to heal by secondary intention. Here we're talking about less than a square centimeter. So we're talking about a little bit of skin avulsion. So all the other choices really sound insane, actually. Oh, wonderful. Any other questions? We actually finished earlier than I thought.
That was good.
Yeah, that is good. We are a half hour ahead of the game.
Can you teach us how to, or tell us how to put that, what's the name of that thing? The splint.
The coaptation splint. All right. Let's see here. Sharing is paused. I want to share. Can you still see my screen?
Not yet. It's like I can see the PowerPoint closing.
Oh,
it's frozen.
Okay, let me see if I can close the PowerPoint. All right, screen sharing has stopped. All right, share the screen. Now we're going to do a little Google action over here. Can you see my screen?
Yes.
Okay, So the coaptation splint. Let's see if I can find a picture of what it looks like.
Oh yeah, I've seen
You may have seen it before. Maybe you didn't know that it was called a coaptation splint. But here's like one depiction. You can make one. You know, Ortho is going to make it out of plaster. I'm going to make it out of Ortho glass. This may be a better depiction. So you're going to have roll that goes up over the shoulder, and it comes down and under the armpit. This is probably what Ortho is going to do. It looks kind of sort of like this. This is a nice preformed coaptation splint. Remember, this is for like proximal humeral fractures. Okay, so this is kind of what I'm talking about, although I would roll this, curl this under the armpit so that you don't have a sharp edge under the armpit. Let's see if I can find one the way I would do it. So this is very high-tech drawing, high-tech drawing here. So if I took that coaptation splint and brought it around, the only difference is I would curl it here so that my open end would be facing inferiorly, not up into the armpit, because that's going to be uncomfortable. That's the one modification. Here's an x-ray that kind of shows you with the coaptation splint in place. Is this definitive? No, but it's better than nothing. But again, they have this basically rough edge going into the axilla, whereas I would make one more turn here like that, if that makes sense. And we can tinker around with this in person at some point. Oh, here's some nice, you can kind of see how it's set up. Oh, that's actually not a coaptation splint though, right?
It doesn't go
it's coming
high.
all the way down here. Yeah, it's weird stuff.
Cool.
You getting tired?
No. Oh, and the leg splint. That one's the other one. The one that EMS places.
Oh, the hair traction splint. Yes.
Yeah.
Oh, this is cool. Is it hair? No, I think it's hair traction splint. All right. And you're not going to make this. You're going to see this. So it's kind of looks like this. Here, it'll be strapped on with a bunch of like seat belts. So if the fracture's here somewhere, you're strapped at the ankle and you're strapped at the thigh at the groin, and lengthening this, you can turn this crank wheel and it pulls the leg out to length. Let's see if there's like a video. Can you still see what I'm showing? All right, cool. Let's see. 30-second video, I think we can do that.
It's that easy. Yeah.
After the obligatory commercial.
This is amazing. How did Ancestry?
This is the application of a hair traction splint. Hair traction splints are designed to be used for mid-shaft femur fractures only. It should be about a hand width below the pelvis and a hand width above the knee, somewhere in here. There could be no other associated injuries. No pelvic fractures, no knee injuries or dislocations, no tib fib or ankle. It's only designed for a mid-shaft femur fracture. First thing we must do is stabilize the fracture site, expose the patient's body by cutting off the clothes to the affected site, remove the shoe, sock, and then check for pulse, motor, sensory. Do you feel this?
Yes.
Have you ever seen
When we
this
first
before?
apply the ankle hitch,
Paula, have you ever seen this before?
No.
Like this contraption? Okay. Pretty cool. Looks like a good video so far.
I thought the lady on the floor was a dummy.
purely,
Yeah, I think he's using an actual lady.
Then I'll measure the traction splint on the non-affected side. Because the leg may shorten with a full femur fracture. We want to measure from the backside around the level of your pocket down to about 6 to 8 inches below the ankle hitch here. I lock into position and prepare for traction.
So you see what he's got there. That's going to pull on the ankle hitch thing that he set up. But first he's going to strap that into her
Okay.
proximal
Please come around.
leg, like
Support the leg.
groin area.
The first strap always to go is the ischial strap. Next, we apply traction. Placing the S ring into the D ring and slide your crank down.
And crank for real.
Okay. There we go. Apply enough traction so that the leg is straightened and there is some relief. Finally, you may apply the straps, avoiding the fracture site and avoiding any joints. Check for pulse, motor, sensory. Most patients with a mechanism enough to cause a midshaft femur fracture may also need to be immobilized using a long spine board. You can use the two together.
Pretty
Thank
instructional.
you.
Yeah.
Awesome.
Any other questions?
No. Do you have any questions, Dan Golden?
No, I'm just making dinner.
Well, thank you both for showing up. I was afraid no one would come to my my session, so at least I had the two of you.
Thank you, Dr. Morris.
My pleasure. I'll see you sometime soon, I hope. If I
Great.
don't see you both, happy holidays. Enjoy the time. And I hope you're not working too much.
Thank you.
Take care.
Bye. Have a good night.
Bye-bye.
Good night. Good night.